Saujatya's request, and many people others have requested, because this is something that we barely touch upon. And definitely, again, Saujatya's suggestion was that who other than Dr. Chandra can be here to teach us and take a master class on cardiac MRI. And we have today Professor Bahl from PGI Chandigarh, who has been teacher to many of us, Dr. Rabin Chakraborty, who presently is in States, so he's joining from States. Missing are, I think, would be joining late would be Dr. Bali and Dr. Hazra and Dr. Wander. And there are many others who are waiting, so let's move ahead and start with the request Dr. Chandra to present his master class today.
Thank you so much, Smit. It's a real pleasure to be among all the friends from PGI. And I've tried to keep up with what's happening, and looks like you guys are flying the flag high. PGI is well represented in all meetings, and so the younger generation really has taken the institute much more ahead. So it's a great pleasure. I apologize, I may not recognize many of you because we are kind of old fogies. I see Dr. Rabin Chakraborty here. I see Dr. B.K. Shastri. So we are all of those vintage. So I again apologize that I don't know each of you personally, but now that the COVID is gone and travel has begun, I'm sure we'll run into each other and we'll rekindle some of the old memories. So thank you. It's a great honor to be here and present to you cardiac MRI related some concepts and some discussion. And please feel free to interrupt anytime. It's an informal discussion. And we can kind of try to see what's going on in this area. So can you see my slides?
Yes,
Yes, sir.
clearly, please.
Okay.
Yes, sir, it's visible.
Yeah. So I'll just, in the next 45 minutes or so, I'll touch big points on cardiac MRI and try to just introduce the topic. I know the audience is very interventional and EP heavy, but it's important to have a sense of this diagnostic imaging modality, which helps you sometimes crack difficult problems. So why is this important? So one of the old papers, which is still a classic, is Mike Felker's paper when he was at Hopkins. And they looked at their big database of cardiomyopathy patients and tried to see what happens to their natural history. And one of the things they found is different causes of cardiomyopathy, as was known, have different outcomes. And so it's important to find out what's causing the cardiomyopathy. And at that time, they didn't have too many techniques to do this. So the dilated cardiomyopathy was one of the biggest groups. And so, for example, if you see from their paper, they had ischemic in a small proportion. These are patients who had no diagnosis before. Idiopathic was a big category, and they didn't have enough techniques to do that. And if we repeat this experiment now with all the imaging modalities that we have, I'm sure we will whittle out a lot of this idiopathic cardiomyopathy group. And so we might end up something like this. We might be picking up conditions like Fabry's. We might be picking up conditions like sarcoid and a whole bunch of things. And this is where the strength of advanced imaging comes up. And it's becoming a very popular sport here now to try to diagnose as many patients as you can with the least amount of investigations. And I would submit to you for this, cardiac MRI seems to be the front runner in diagnosing various forms of heart disease. So I will try to kind of introduce the concept of using MRI, mainly based on dilated cardiomyopathy. And then we can also talk about unexplained heart failure. So we'll kind of start with unexplained heart failure. So cardiac MRI tries to tell us in three different buckets. It's an easy way for us to think about it. Are we dealing with a hypertrophic heart? Are we dealing with an arrhythmic heart? Or are we dealing with a dilated heart? And when we're talking about a dilated heart, it's either HFpEF or HFrEF. And today I won't cover too much on the HFpEF side. There is a lot of new data coming there too, where with MR, you can look at diastolic filling curves and a bunch of things, but we'll stick mainly to HFrEF. And one of the things we need to understand before all this is, why is CMR unique? I mean, we have echocardiography, which is advancing in leap and bounds, and now we have new techniques. We have 3D echo. We have cardiac CT, which gives beautiful morphology as well as coronaries. So why is CMR still so valuable? And the main strength is precise tissue signatures and its ability to give you a one-stop shop. So here is what cardiac MRI can do, right? You can have anatomy and function. You can get beautiful pictures. You can get a very good myocardial perfusion study. And then most importantly, you can get tissue characterization, what exactly is happening in the tissue. We won't touch too much about myocardial perfusion imaging, but suffice it to say that basically we do the same like we do in a nuclear study. There's a rest and a stress perfusion. So here is a rest perfusion, and slowly you will see the whole myocardium becomes uniformly white. And then in a stress perfusion, this part remains white. When you perfuse, here is the dye coming, it's white. And then you get a big subendocardial black area, which is suggestive of ischemia in one particular coronary territory. It's subendocardial, which makes it a coronary origin. So this would give us a good sense whether it's a stress-induced myocardial perfusion defect. If you have it in both stress and rest, it's most likely to be an infarct or an artifact. And there you got to figure out what's happening. There is a common artifact that throws off a lot of early readers. It's called a Gibbs artifact, where the interface between the cavity and the wall is so stark that you often get a little black rim here. And that's sometimes diagnosed as an ischemic defect. But then if you are very meticulous and you see that this defect persists over many frames and seen in more than one view, that makes it more reliable. How accurate is stress perfusion? This is an area of controversy, but most people would believe, based on at least one head-to-head trial between nuclear imaging and stress myocardial perfusion, that stress myocardial perfusion was better in terms of diagnosing ischemia as well as prognosis. Part of that trial, which was a Lancet study, had a controversy in the sense nuclear imaging did not perform as well as what was known in literature. So that area is still a little gray. And part of the criticism also was that you, in addition to getting myocardial perfusion, you're also getting better wall motion abnormalities and gadolinium data, which if you all put together, your diagnostic accuracy and especially your prognostic accuracy is much higher than a nuclear imaging, where you don't have that kind of fidelity to get all that information. So be that as it may, stress MR is becoming a very popular vehicle for ruling out ischemia. You could also argue that after the ischemia trial, whether going and detecting ischemia is really that important, but that's a topic for a different day. But suffice it to say that stress myocardial perfusion is as good or probably better than nuclear myocardial perfusion image. What about anatomy? You all know that the anatomy is very exquisite. You can see here, here is a patient of mine with severe dilated cardiomyopathy. You can see the whole heart enlargement, the change in the shape from a conical to a globular shape. You can see RV function size very nicely identified. You can see the valves, you can see even MR, and this can be quantified very reliably. We'll talk about that later, how much more valve quantification or MR quantification is better than echo. There is a lot of data in that area. And then you get exquisite morphology with this. Morphologic patterns are important. So here are 6 examples again from my patients. Dilated cardiomyopathy, which we already talked. You can see amyloid, big atria, stiffer kind of small heart with thick ventricles, RV dysfunction, some effusions. Same way with ischemic heart disease, you can see where which territories are involved. You can see endomyocardial fibrosis. Apex is obliterated here. You can see beautiful delineation of LV non-compaction. And of course, restrictive cardiomyopathy. So it's turning out to be a very useful technology. But then echo also can do morphology. Other techniques also can do, not as well, but enough to get good clinical data. So where is its main strength? Its main strength is here. We're getting tissue signatures, which no other technique does. And here is what I'll try to explain to its virtues here. So here are 2 patients, right? You have one, both are heart failure. One is a thick heart. One is a heart with a regional wall motion defect. And current imaging technologies don't, apart from an angiogram, don't tell you anything more. But here is what MRI does. So if you do what's called late gadolinium enhancement, which is a technique trying to identify macroscopic or scar, like the big scars we are used to see in pathological specimens of myocardial infarction. The technique uses a special sequence called PSIR, which tries to make the normal myocardium completely black. It's kind of nulled up. And the areas that cannot be made black like this are thought to be scar. And there's good histologic confirmation. And if you take a biopsy from this area, it will look like this: extensive collagen deposition and macroscopic scars that you can see with your naked eye. So this is the classic scar of myocardial infarction. The pattern of scar also helps you. The coronary distribution, you can see here it's subendocardial, and at some places it's full thickness. Subendocardial in a coronary distribution tells us this is because of an ischemic insult and probably total occlusion and death of the myocardium there. The thickness of this white stuff compared to the black stuff gives you some sense of how much the wall will recover after revascularization. It's called viability, but it's not purely viability. We'll talk about that later in the discussion. It's essentially telling you what part is dead. It doesn't tell you what part is alive. So it doesn't tell you whether this is alive or not. It just tells you this white part is dead. Sometimes you get this black thing within the scar, and that's microvascular obstruction. And microvascular obstruction moves the prognosis to a whole new level. It is a marker of all bad things happening, including ventricular dilatation, more arrhythmias, more heart failure, and more death. So that is replacement fibrosis. This is the workhorse of what we do in MRI. But there is other type of heart failure, for example, in HFpEF or hypertensive heart disease, where if you do the same late gadolinium enhancement on this heart, you will find that it doesn't show up with these kind of scar. It may be LGE negative. So this white scar is called late gadolinium enhancement because gadolinium is a dye we give. And so this is LGE positive, but here you will get LGE negative, but he'll still be in heart failure. So people then try to find out what techniques you can use to find LGE fibrosis there. And then even though LGE is negative in this heart, you can still see fibrosis if you take a biopsy. And this is this fine, lacy fibrosis, unlike this macroscopic fibrosis that you found in the other infarct. And so this is now tested with 2 techniques called T1 mapping and ECV. So what's T1 mapping? It is trying to map every pixel in the heart based on relaxation times. And so it is colorized like this. There's a sequence called look locker or MOLI, modified look locker sequence, where different sampling is done to see relaxation times, and that's mapped onto the myocardium. There's always a little color bar on the side which tells you what is normal, what color is abnormal. And so this would be a normal study. This would be an abnormal study where you start getting patches of yellow or red, depending upon how it is colorized. And that correlates both with macroscopic fibrosis as well as microscopic fibrosis in areas where there is no late gadolinium enhancement. This is turning out to be a very powerful technique. But one thing to remember about T1 mapping, you will hear a lot of papers which say T1 mapping is diagnostic in amyloid or diagnostic in sarcoid or wherever. But you should think about it like it's like troponin, right? So it's increased in any kind of heart disease. It doesn't have to be infiltrative or fibrosis or anything. So if you think about it, the troponin tells you both abnormal myocyte component as well as the interstitial component. So how do you decide whether it's myocardial or interstitial? Then you go to what is called ECV, where ECV tries to separate the extracellular component of the problem from the myocardial component of the problem. And some sophisticated analysis are now trying to determine the changes in the myocardial compartment, myocyte volume, myocyte regression, myocyte hypertrophy, those kind of things using these techniques. T1 and ECV are also important in identifying nature of infarcts. Here is a patient with area of LGE, but on mapping, you can see area of LGE is picked up, but it's also picking up fibrosis in an area where there is no LGE. And this, as you can imagine, will give you prognostic information because now you can identify fibrosis much more clearly. ECV mapping is again done in the same way. You map it across the myocardium. The disadvantage of ECV is you need to give dye. T1 mapping can be done native or it can be done post-contrast. ECV mapping needs pre and post-contrast numbers and hemoglobin, so it needs dye. And if somebody has contraindications to that dye, it is a little tricky to do. There are not that many contraindications to dye with the new gadolinium compounds that we use. Previously, in renal failure, we would avoid it because it used to cause a condition called nephrogenic systemic fibrosis. It doesn't do that anymore. So we still use it in renal failure patients, but you want to be cautious about using dye because one of the bad things that happens with this gadolinium compounds is it goes and stays in the brain tissue, especially in the basal ganglia area, people say forever. So every time you give gadolinium, you leave a little of that in the brain. What does that cause is not very clear. The European guys have put a little bit of a equivalent to what's called a black box warning in the US that this dye can cause problems, but nothing has been identified as yet. The US doesn't put a black box warning for that as yet, but it's something you got to be careful. There's no point in getting repeated MRIs if this dye is staying there and you don't know what it's doing 10, 15 years from now. ECV is again given as a percentage. So a combination of T1 mapping, which tells you everything about the whole heart, ECV, which tells you about the extracellular compartment, allows us to identify which areas are problematic. Then there's the other area where CMR is very useful is identifying edema. In the past, we used to do sequences which were called stir sequences, where the edematous area would be white, non-edematous area would not be white, it would be normal. And this helped us to detect early infarctions at a time when we still didn't see gadolinium, but you would see a area of white in a coronary artery distribution that would tell us there is something wrong here. There is early edema, early myocardial injury. And there have been studies where people went and did OCT on these patients and found plaque ruptures in the same territory. So that used to be the old technique that we used to do. But now again, we do mapping, which is called T2 mapping, which is more accurate than the previous black and white kind of contrast that we used to look. And that T2 mapping is now the thing that we use the most. So T1 mapping for the whole heart abnormality, whether it's hypertrophy, whether it's fibrosis, whether it's infiltration, ECV to identify what's happening in the extracellular compartment, and then edema mapping to tell us if there is excess of edema. And these are the things which we use in myocarditis. Lastly, it can tell you fat. Here is, there are fat suppression sequences. Here you can see fat in the myocardium, white stuff. If you have special sequences which suppress fat, they are triple inversion recovery kind of sequences. It gives you black. And so if you have a tumor or something, you can identify that based on fat sat image. So that's the basic thing. If you have to explain this to your fellows and want them to read more, there are lots of papers out there. One of this is from my group in Circ Research in 2016, which shows what happens with when various kinds of infiltration or damage happens, what happens to T1, T2, ECV. So it's a handy table to look at. So then the question comes, how good are we at diagnosing ischemic versus dilated cardiomyopathy? So that is one of the simple things. If you remember, when a patient comes to us, we don't know what's the etiology of diagnosis. Our first choice is it ischemic or dilated? And once it's dilated, what are the subfractions of dilated cardiomyopathy? Is it idiopathic or is it something else? We all think it's very simple, like you get an angiogram and you know it's ischemic. If the angiogram is normal, it's dilated, but that's not true. CMR is revealing lots of nuances. For example, here is a true dilated cardiomyopathy. Coronaries are normal, no late gadolinium enhancement, fine. True coronary artery disease, there's a coronary artery lesion, there's a gadolinium LGE in the territory of the coronary artery disease. The patient has heart failure, significant sized infarct. That is true ischemic cardiomyopathy. Same way, you can have true ischemic cardiomyopathy with normal coronaries and a large LG. You have a large LG here. Clearly, this is an LAD infarct. You have normal coronaries. This was revascularized. Now the question is it ischemic or non-ischemic? If you had stopped with the angiogram, you would have called this non-ischemic. Now that you have CMR and late gadolinium enhancement, you would call this true ischemic cardiomyopathy. Same way, you can have true ischemic cardiomyopathy with 3-vessel disease but no LGE, right? And you can have true dilated cardiomyopathy with incidental CAD. In the olden days, if there was coronary artery disease and heart failure, we would call it ischemic cardiomyopathy. But without any gadolinium enhancement, it's tough to say it's an ischemic cardiomyopathy because a sufficient amount of tissue is not dead there. So now it brings up the question, can you get so much hibernation, whole heart hibernation, that causes the cardiomyopathy and it's still ischemic? But that would be so rare. So this would be a dilated cardiomyopathy with incidental coronary artery disease. And if you go and fix the coronary artery disease, it's unlikely to change the prognosis. So these are the kind of data that are coming out, which might change our thinking about ischemic versus dilated cardiomyopathy. And it's important because there are downstream consequences in the form of either treating them with revascularization and even prognosis. What about LG scar patterns? They allow you to diagnose the etiology. For example, let's concentrate on the top panel here. So in the top panel, this is a normal heart. We said we have nulled the myocardium and made it black. There is nothing, no gadolinium there. Here is a MI in the LAD territory, non-viable, full thickness. And there's a nice paper from Ray Kim when he was at Northwestern, showing that the thickness of the LGE predicts revascularization. It was a New England Journal of Medicine paper. If you have, so this is the normal myocardium, the black one, this scar is the white one. If the ratio of normal to abnormal is more than 50%, the chance of revascularization, improving wall motion in that territory is very low. Once you get to 75% or beyond of scar thickness, it's very, very unlikely it will improve. That would raise the question, do you want to revascularize this patient or not? Remember, I said there's a little controversy about viability in this area. One of the things to remember is, and often our fellows don't know this and they confuse it. So like when you do a nuclear test, it is telling you which part is alive, right? The nuclear tracers need to be picked up like potassium analogs. They need pumps that are active and the cell is picking up the nuclear tracer. So the nuclear techniques for viability like PET are telling you which area is alive. Whereas CMR is just telling you which area is dead. So it's telling you more about this white area. But if a white area is surrounded by what looks like a black area, you will not know whether this area is viable or not. And that's why they use an indirect method saying what fraction of the wall thickness is scar. So if you have a severe amount of scar there, it's unlikely to improve. So that's the way the viability. And so this would be a non-viable myocardium. You could have a viable myocardium. Here you have a nice thin peel of subendocardial scar and it's less than 25% wall thickness, and this would be viable. Again, there is a lot of controversy whether viability is important or not, but if you are a believer in viability, this would be a good way of trying to identify. Then you can have dilated cardiomyopathy with wall motion defects or even thinning with no LGE. And there's a nice paper in JAMA 7-8 years ago where CMR showed something which was very interesting and I found difficult to believe. All of you probably remember your echo training. You would say that if a wall is very thin, say 3 millimeters or 4 millimeters or less in a patient who had an infarct, that is all scar and that will never improve. But this paper by Ankur Gulati's group from England showed that if you don't have late gadolinium enhancement there, but the wall is thin and you revascularize that wall, the wall gets back its thickness. So that is amazing, right? A wall which looked thin and we said this will not ever revive. If it did not have gadolinium there and you revascularize, that again restored its thickness, which raises all kinds of possibilities. What does a thin wall mean? Does a thin wall mean it's like fibrosed and scarred, or a non-contractile wall can become thin? So these are questions that have not been answered, but they are fascinating questions. Look at the lower panel. So the lower panel talks about sarcoidosis, right? There are different patterns in sarcoidosis. There is no one diagnostic pattern. The commonest pattern is septal involvement and posterior lateral involvement. But you can get any pattern. So when somebody sends a patient to the lab and says, diagnose sarcoid, we cannot diagnose sarcoid. We can just tell you what kind of scar patterns are consistent with the probability of sarcoid. And the highest consistency is if you get septal, mid-septal. Again, this is not following a coronary territory. These are random areas of GAD and sometimes in the posterior lateral wall. There are sometimes reports or images you will see where you will see GAD near the RV insertion point. So see, this is the RV. It's inserting into the short axis of an LV. Sometimes you get gadolinium enhancement in these insertion points. That used to be thought to be a important indicator of RV overload or pulmonary hypertension, but or even hypertrophic cardiomyopathy. The early paper said that is very common in hypertrophic cardiomyopathy. But now people believe that is non-specific. So it may be a hemodynamic effect or it's just non-specific. So just having LGE in the insertion points of the RV is not enough. What about myocarditis? Myocarditis again is not a directly CMR diagnosis, and lots of CMR centers overdiagnose myocarditis. And the reason is they think a pattern of LGE, which is subepicardial, especially on the lateral wall, in a clinical situation consistent with myocarditis could be myocarditis. So essentially it is talking about scarring. It's often seen here, but it can be seen anywhere. About 10 years ago, the German groups tried to identify whether a certain etiology of myocarditis will give you a certain signature on the gadolinium, but that turned out to be enthusiasm ahead of data, and that never panned out. So essentially in myocarditis, you just get gadolinium and you get edema. So a combination of gadolinium and edema helps us make the diagnosis of myocarditis. How about amyloidosis? Amyloidosis again is like a a difficult diagnosis even for CMR. We'll talk a little more as we go through, but one of the classic things is widespread GAD, random GAD, which is not following the coronary pattern. It's mostly mid-myocardial. And one of the things that happens is we cannot make the normal myocardium black. If you see on the top left, the normal myocardium, when you null the myocardium, it becomes exceedingly black. Here, it doesn't become black. So the difficulty, so you might hear in papers, inability to null the myocardium. That should raise the question of amyloidosis. Those of you who are more EP oriented might find fascinating things happening in the MR world. There are a whole set of arrhythmogenic cardiomyopathies, especially involving the LV. A dilated cardiomyopathy, sometimes you can get this non-specific mid-myocardial stripe, like see this white stuff in the middle of the myocardium. That's non-specific, that you can get in any dilated cardiomyopathy. But usually it's not a full ring, like you see here. And there are 2 or 3 things coming up that if you have filament cardiomyopathies, which are an arrhythmic form of cardiomyopathies, you often get a subepicardial ring that may sometimes become complete. And if you have desmoplakin mutations, often it's again a complete ring, but it is more mid-myocardial. So these are the things that are coming up. So that's becoming fascinating. And JACC Imaging, which is the journal I edit, just accepted a paper last week looking at genotyped patients with various kind of arrhythmogenic cardiomyopathies and their LGE pattern. And this circular ring-like pattern seems to be very predictive. Now, LGE scar allows you to prognosticate, right? So, for example, here is, you look at the top panel first, top left, the extent of LGE, the location of LGE, especially if it's a septal and a lateral wall together, both predict a high incidence of bad outcomes, and the septal plus lateral wall LGE predicts a higher incidence of sudden cardiac death. But any LGE anywhere predicts CV mortality, arrhythmic events, or even hospitalization. And the interesting part is it predicts prognosis better in patients with better EF. So mildly reduced EF, moderately reduced EF have greater predictive value for LGE than severely reduced EF. So that's a good thing, because right now the 35 plus EF is a tricky condition. Okay, so we just talked about this ring LGE. That's something to keep in mind. If you see something which looks like a ring, that sounds like it's a bad prognostic factor, whether the scar burden is high or low. So that is something to keep in mind. What about finding LGE in structurally normal hearts? So you must have got this theme by now. LGE is bad, but what if a heart is not dilated, it's not hypertrophic, it's contracting? Okay, what does LGE mean in that? And this is a recent paper from one of the British groups, Sanjay Prasad's group, again in JACC Imaging, showing just a random bit of LGE without any other structural changes may be benign. So when it's associated with some kind of a disease morphology, then it's a problem. How about T1 and ECV? Does it have any advantage over LGE? It certainly does. So T1, whether it's a heart failure endpoint, whichever way you measure LGE, T1 seems to add prognostic data in dilated cardiomyopathy over and above LGE. What about patients who are LGE negative? Again, T1 mapping. So you can see here on the top middle panel here, and ECV, both will separate people who will have events or not. And the events start very early after your diagnosis, suggesting these are robust markers of bad outcome. How about CMR in decision making? So we know that fibrosis is bad. There's a very famous paper by Hugo Eitel, about 10 years ago in Circulation, which divided patients with EF more than 35 or less than 35, the ICD cutoff range, and found that if you have EF more than 35 and they had LGE more than 5% of their myocardium, they did worse than EF less than 35, but LGE less than 35, 5% of the myocardium. And that raised a lot of excitement that whether ICD decisions could be made based on that data. That kind of did not pan out because while it separated the risk between the two groups, the absolute event rate was very low and it did not justify giving ICD in a huge bunch of people just to save a few events. And that has been reproduced a little more now across a bigger territory. And again, here it shows that when you kind of stratify this with LGE and EF, having an LGE plus EF more than 35 is at a worse risk than having just an EF of 20 to 35%. So low EF alone is not as bad as high EF, but still abnormal EF with LGE positivity. And Andrea DiMarco kind of put this into a little algorithm. So if you have LGE negative EF more than 20, that's a low risk group. This is surprising, right? We would say EF of 20 to 25 is high risk, but in them, if there is no LGE, that still becomes a low risk. And then when you have both abnormal, that gives you a highest risk, and then you can triage intermediate risk there. What do we know from trials? Has this ever been tested a little bit? Here is some data which explains the results of the Danish study. As you know, in the Danish study, there was some controversy whether ICDs are of benefit in dilated cardiomyopathy patients. So here it shows that if you take patients, look at the top right corner, if you have no scar, there was no freedom of death, whether from CV death, whether you have ICD or no ICD. That means there was no benefit of ICD in these patients with dilated cardiomyopathy. While if you had a scar, that was the group where ICD really separated dilated cardiomyopathy patients in terms of mortality or CV death, all-cause mortality or CV death, suggesting the people who benefit in a population which is like a Danish study population would be those with a scar. So what do we do in 2023? So the way we evaluate dilated cardiomyopathy is a whole host of things, right? We could start with cine imaging, right? We will give you volumes, mass, function, right? Regional wall motion, shape, those kind of things, probably better than anything that you can do. Then we go to scar and fibrosis imaging, that is LGE. We could throw in perfusion between these two before you get to LGE. LGE is a late gadolinium enhancement. The word late there means you give the dye and wait for 10 to 12 minutes before you start imaging. That's why it's late. There's also an early gadolinium enhancement that you can see with acute myocardial injury or edema. That's called EGE. We don't use that very much. But late gadolinium enhancement is that scan which you do 10 to 15 minutes later. So that is LGE. While you're waiting for this, you would run a perfusion study, the stress and rest perfusion, the rest and stress perfusion study. And then you could also do tagging, which we don't do as much, but it's very good when you have constrictive pericarditis or those kind of things. So normally all these little markers, white and black markers, they all contract and relax in a certain sequential pattern in systole and diastole. And if those patterns break, it tells you there is a regional abnormality, and in constriction that can also help you make a diagnosis. Then we do T1 mapping, T2 mapping, looking for both. And then if it's possible to get a pre and post measurement, then you can get ECV after edema. And then if there are any special conditions in the request, you could do special things for iron or things like that. There is also something called feature tracking global longitudinal strain, which is looking at the same thing what you look at echocardiography, which is like tracking. It's a little different. Unlike speckles that are being tracked in speckle tracking, here we are tracking the edge between the ventricle and the myocardium. It still functions like GLS. And then that can provide the same value that is provided by echocardiographic GLS. So where are we now? So should every patient with dilated cardiomyopathy get a CMR? In my practice, it seems like that every dilated cardiomyopathy or even every ischemic cardiomyopathy is getting to the lab to get a CMR. but that's kind of an overkill. So it's an expensive test. It takes time. These are not like short tests. They take about an hour. So what does the data tell us? So there are two ways to look at this. One is to look at what are the appropriate use criteria and what are the guidelines. If you look at the top, this is the ACC appropriate use criteria for patients to clarify the diagnosis of heart failure after initial diagnostic testing. And if you remember, in the appropriate use criteria, anything that is green is highly recommended. 7 to 10 is the score that they give, 10 being the highest, and anything which is red is generally not recommended. And if you look for various tests, including transthoracic echo, strain, exercise, nuclear, CT, angiography, and you can see CMR uniformly, whether it's a new or increasing heart failure therapy, whether it is comprehensive evaluation of undefined cardiomyopathy, evaluation of suspected sarcoidosis or amyloidosis, or hypertrophic cardiomyopathy, it gives a very high rating of 8 or more. So the appropriate use criteria seem to suggest that any of these questions go and get a CMR. What do the Europeans say? The Europeans say is like, they give a 1C grading for assessment of myocardial structure and function with poor acoustic windows. It's tough to say this is a class 1 indication because that hasn't been tested, but it probably makes sense. If you can't see it on echo, you might want to see something else. And they also say that you need to 1C for various kind of infiltrative disease, Fabry's, inflammatory disease, etc. The US guidelines are a little more reserved, right? They say when echocardiography is inadequate, that's the time you can think about this. And then they just say it's useful for diagnosis and management of cardiomyopathy, but they are appropriately a 2A indication rather than a class 1 indication. There's been only one trial which is looking at this. So this is a Canadian trial which randomized patients, eligible patients with non-ischemic heart failure, to echo plus routine CMR, that's the blue, and then echo plus selective CMR, that is the red. So they randomized these people and then followed them up for 12 months for two things, whether CMR allows you to diagnose more, and second, does CMR allow you to prognosticate better? So look at the left lower box first. So here the orange is selective CMR and blue is the routine CMR. And you found that a specific cause is ultimately found in 35 to 40% of people in both groups. It's just that the non-CMR route takes a little longer, but you arrive at the diagnosis eventually. If it is ischemic, hypertrophic, generally there is not that much difference. Inflammatory, there wasn't a difference, but then these were chronic inflammation. They were not acute inflammation. So that makes sense. If it was acute inflammation, I'm sure CMR would be better. In the group of dilated cardiomyopathy, CMR seemed to have a 20% more efficacy in diagnosing etiology of heart failure. What happens if you diagnose the etiology of heart failure one way or the other? It appears that over a year, the event rates, including survival probabilities, were not any different. But if you had a diagnosis, a specific etiology that CMR found, which regular testing did not find, it turns out that your outcomes are slightly better. So there is some advantage, and this was adjusted for the MAGIC score. As you know, the MAGIC score from Sanjeev Shah's group is a very powerful prognosticator. So when both groups are adjusted, it appears that CMR lets you diagnose some things a little early, maybe helps you identify a few more causes, but it's not a huge game changer. So which brings you to the question that how do we be cost effective about this? When should we say something should be used or something should not be used? That again depends on local practices. In the US, the horse is out of the barn now. So now it's very difficult to put any restrictions on CMR. It's done routinely now, and pretty much every heart failure patient seems to get, despite this kind of data. But we'll see what happens in future once the insurance companies get a little more tough about pre-authorization of CMR tests. Right now, there's no pre-authorization. So, Smith, how much time do we have? Do we have 10 more minutes or should I stop now?
Sir, we have as long as you want, sir.
So let me run through a couple of scenarios quickly so that I don't overwhelm the thing, but let's talk about hypertrophic cardiomyopathy, right? So again, HCM and amyloid are the two things that come. One of the vexing questions on the clinical bedside is differentiating LVH syndromes, right? Here I've shown 4 or 5 different causes of LVH that we see in our lab often, whether the hypertrophied heart is hypertension, whether it's HCM, whether it's amyloid Fabry's or Dannon's. Some pediatric practices have Dannon's that we see sometimes. So hypertrophic cardiomyopathy, what is the role of CMR? It's a very, very prominent role. And the reason is it gives you beautiful morphology. Now we are used to having a typical morphology of hypertrophic cardiomyopathy, but you can essentially get hypertrophy anywhere. You can get it here, you can get it here, anywhere, and all kinds of oddball shapes. And scar is one of the criteria they use for ICD decision making. So that is very important. Hypertension, again, we see a lot of these patients which have to be differentiated between hypertrophic cardiomyopathy and this. Sometimes in hypertension, you get this distal upper septal knuckle, which makes it a little tricky. Amyloid, of course, we'll talk a little more. High ECV is a very prognostic or diagnostic factor. Fabry's, again, is a very interesting condition. This is one of the few conditions where the T1 is low. So the lower the T1, the worse it is. So that's a very useful thing. Normal T1s, depending upon your labs, you have to calibrate your own lab, is in the range of 950 plus minus 50. These guys are in the 600 ranges. That's very diagnostic. Dannon is exactly like hypertrophic cardiomyopathy. Thick septum, LVH, they present like a hypertrophic cardiomyopathy. But one curious thing on the LGE is that somehow the septum seems to be spared in Dannon, unlike HCM, where the septum is nearly always involved. So if you have a hypertrophic cardiomyopathy that looks like a classic hypertrophic cardiomyopathy, but has no LGE in the septum, you should think about Dannon's if the age group is correct. So there are multiple prognostic variants in HCM, right? So you have the classic curve and the reverse curve morphologies, right? So if you have a reverse curve septal morphology, those guys seem to have more fibrosis and a more malignant course than a classic morphology, right? So that's coming from a big registry. So scar in HCM again is bad, as you can see. Uniformly, most studies have shown all-cause mortality, cardiac death, SCD, heart failure death, everything is increased once you have scar. And how much scar you need is kind of highly variable. 15% of the myocardium or more. For example, if you see this curve, LGE on the x-axis, complications. So at 15%, you have increase in risk. So that's why, even though it's continuous, most ICD recommendations would look at that amount. The new thing that's come only in the last year or the last 6 months is that if you have LGE in the subendocardial region, in addition to the regular LGE in hypertrophic cardiomyopathy, this may involve an ischemic component at the microvascular level, and it's supposed to have a worse prognosis than the regular one. So what about scar? Does the scar progress or regress in HCM? Mostly the scar doesn't regress, but there are a small group of people where the scar can progress about 5% a year, and they have one of the most malignant courses that you can find. So I'm not advocating for you to get yearly CMRs, but if you have 2 CMR studies and you show that the scar has progressed, you probably want to be a little more careful. Mapping seems to do the same thing like in heart failure. It's better than the ESC and AHA guidelines for predicting ICD risk, ICD use or shock risk. And then one subset that's coming up with the advent of HMR, especially from the St. Bart's group in London, is that apical aneurysms detected especially nicely on CMR, as you can see here. In echo also you can see, but you cannot size it as well. Aneurysm sizes more than 2 centimeters are predictive of sudden cardiac death, stroke, and combined endpoints. So that's something to think about. Amyloid, contrary to what is believed, amyloid is a nuclear imaging diagnosis. It's not a CMR diagnosis. We get requests saying suspected amyloid for diagnosis, and that's a wrong way. Still, PYP scan is the workhorse of amyloid. So anybody you need thinking of amyloid, screen him with PYP scan first. And then once that is done, then you can come to CMR to see what is the tissue damage because of amyloid. There is no diagnostic pattern. Again, this surprises people. There is no diagnostic pattern of amyloid in CMR, but a combination of things. For example, you have a diffuse late gadolinium enhancement, like we talked about before, right? Where you cannot null the myocardium. There is no black myocardium anywhere. Everything looks white. Very high ECV. ECV is into the 50s, and normally it's less than 30, 28 in my lab. But if you're in the 50s, that's very diagnostic, and a high T1. So those are the diagnostic. Again, mapping adds value here because you can have a condition where there is no LGE, right, and like here, and yet you can have some ECV abnormality. So that makes a difference. Between T1 and ECV, what should you choose? Probably both for diagnostic odds and for prognostic odds. ECV seems to outperform T1 and LGE in the diagnosis of amyloid. So that's something to keep in mind. And one of the big things that you'll start hearing now is regression of amyloid. So when you use tafamidis and all these very expensive therapies, and I think we have probably 50 plus patients who are on tafamidis. It's expensive therapy. It costs nearly $100,000. So you need to know whether the tafamidis is making a difference or not. And it appears that if you track ECV, that's a good marker. So that's something to think about. A little bit about arrhythmic hearts, since the EP is taking off in India. So last year I had a chance to visit with the Indian Heart Rhythm Society people, and you guys are doing fantastic things. So here is something that might be of interest for you. There's a whole new interest in arrhythmogenic cardiomyopathy. Previously, we used to talk about ARVC. There was a whole group of conditions which are arrhythmogenic left ventricular cardiomyopathies. It's like a miscellaneous basket of things, including lamin, sodium channel, filamin, desmoplakin, and other things like left LV dominant cardiomyopathies that was described in England. So there's a whole host of things that can be done. And the problem is there is no specific criteria that you can diagnose. And the question was, can you have a distinct arrhythmogenic imaging phenotype with CMR? And if you look at tissue of people who died and correlate them with their CMR scans, you can actually cluster these people into 4 different involvements based on RV, LV, or fibropathic component, 4 different. They seem to have different mutations and different kind of EKG findings. For example, cluster 3 and 4 seem to have a certain kind of diagnostic things compared to cluster 1 and 2. Can we reproduce this in CMR? And here is one of the first papers that is going to do this. This is, as I told you previously, was a genetically mapped study, a phenotype study looking at these things, and it came up with these criteria. The filaminopathy, you would have this subepicardial ring. Any arrhythmogenic cardio, once you have a full ring, that's a problem. Laminopathies are more in the septum and middle, whereas myocarditis, which sometimes is confused with this, is more of subepicardial inferolateral. So these kind of signatures might help us correlate genotypic versus phenotypic things. So these ring-like patterns seem to be becoming very common in certain genotypes, filamin compared to other cardiomyopathies. And you can also detect some of this even before SCAR and LV dysfunction has set up. So that is something to remember. There are no clear patterns in Titin cardiomyopathies or even LMNA cardiomyopathy, which, as you know, is a very malignant form of cardiomyopathy. So how does myocardial fibrosis affect arrhythmic events? The theory now is, if you look at a scar, there are areas of gray between the white and the black. And that is supposed to be the gray zone areas where all kinds of, the cell is not dead, the cell is not alive, but it is very unstable. And that is supposed to be. And here is a paper from Levia's group who showed that high area of gray zone fibrosis seem to be very arrhythmic. And then CMR finally can be used to characterize what happens pre and post CMR. This is a Brigham experience of many hundreds patients with VTVF. And they showed that pre and post CMR, you can make a big difference in idiopathic cardiomyopathy and myocarditis. And then, of course, the events are highly determined by how much scar you have and scar patterns. Lastly, this is like an interesting thing that you can randomly catch, and sometimes it may save a life. This is one of the patients at our center who was a high-level athlete who collapsed on a field, and there was no clear diagnosis despite extensive investigation. And the only thing we found was in one of the SSFP sequences, there was a white spot here. Normally, SSFP looks nice and black. We found an area which was persistently white. And then when a CT was done, it looks like an area of fat with very low Hounsfield units. And it turned out that this is one of those rare cases of LDAC, which was described by Sanjay Prasad 20 years ago, where you can get a fatty deposit within the myocardium on the left ventricle for unknown reason, and that becomes a focus of arrhythmic events, including sudden cardiac death. So that was one of the conditions where we could diagnose. And then, of course, we talked a little about sarcoid, which is a arrhythmogenic condition. And there again, there is no clear pattern, but this is a nice study from our institution where we looked at what happens in people who die of sarcoidosis and see what kind of patterns of scar they had at histology, and then tried to replicate what type of scars are seen in CMR patterns and what happens to their outcomes over a long period of time. And as I said before, if you have a septal and a lateral wall scar, those are the groups which seem to have the highest event rates down the road. So this is something to think about, that when you see a sarcoid patient with scar in the septum and the lateral wall, that may be the people who have the highest pathologic correlation. And then this is my last slide. What's coming down the future is a radiomix of CMR scans. So now you have these scars. Can you pick up more information that the eye cannot see from the CMR scar? And you can run these radiomics. And here is a study from Beth Israel in Boston, where they looked at a huge group of patients with hypertrophic cardiomyopathy. And they were subjected to both the AHA, ACC, and the ESC model of clinical risk stratification and seeing outcomes. And then they ran a radiomic screen. And it turned out the radiomic screen could predict sudden cardiac death much better than the two criteria that we have. I mean, it's true, both of the ESC and the AHA criteria are not very good anyway. They are like the best we have, but looks like the ability for machine learning to learn patterns of scar might allow us to stratify these patients better than the standard models. So I'll stop there. We can address some of the issues during the discussion. Thank you very much. I greatly appreciate this opportunity.
Thank you, sir. Before, there are few questions that I have, like in a situation where we cannot do a CT angiography or CT analysis for implanting a aortic wall, a TAVI, where can MRI help us in such cases? One. And second is there a possibility, like it is now being suggested that in patients with the valvular disease like aortic stenosis, in the long term, if we delay the valve replacement, it results in poorer recovery of the LV. So somewhere there MRI can play a role, which we can pick up those patients where we can pick them early and suggest that these may benefit with a valve replacement.
Yeah. So you are absolutely right. I'll answer the second question first. So the second question is, does that help in aortic stenosis? So I will So there is a paper by Mark Dweck. I will email it to you and you can distribute it to the group. There is a paper from Mark Dweck, which looked at 3 categories of myocardial involvement in patients with aortic stenosis awaiting valve therapy. One was patients who had LGE, which is like fibrosis. One group was patients with ECV abnormalities or T1 abnormalities, but no LGE. And then just regular aortic stenosis without either. So he kind of tried to stage that as stage 1, stage 2, stage 3. And the patients who had LGE and high ECV were the ones who had the worst outcome. So that was a highly cited paper. So there is evidence that as you have more fibrosis, as you have more extracellular volume expansion, you do poor. Whether that translates into upcoming a priori decisions, that's being tested in a study by the same group from England. And we have those results in maybe 4 years. And they are trying to use tissue characterizations to predict when to intervene, just as some other groups are trying to use GLS to predict when to intervene in asymptomatic aortic stenosis. As far as the TAVR question is concerned, some of the very expert centers are trying to push it, that we can use MRI to help with TAVI. It's not that great. I mean, you could probably get some anatomic information of the aorta, but it's not as good as CT, definitely. And it's rare that we cannot do CT in a patient, at least in our practice. They seem to be okay to do it in pretty much everybody. So it can give you some information, but the anatomic information is not as good as CT or even echo. For one, it's in MRI, you have to plan your planes, right? You have to catch the right plane. And when you say, okay, this is the size, you have no way of knowing you caught the correct plane. Unlike CT, where you can have various kind of manipulations and get it. So right now it's not there. But for valve quantitation, like whether it is severe or not severe, especially on the MR side, that is big.
I wonder if I may just add, sir, is there something about T2 relaxation time?
Yeah, there is.
Recovery of LV function in patients with LV dysfunction post-TAVR, patients who have already baseline LV dysfunction. This is something that we're trying to work on. So one of the things which kind of tried to predict, I mean, I think divide the quartiles, sorry. And I think they found something about T2 relaxation time, if I may ask.
Mainly T1 quartiles are highly predictive. T2 is more on the edema side. It's not as predictive because in chronic conditions, it's not. T1 has been, it's like troponin. In any condition, it is showing prognostic benefit or outcome benefit. So definitely there are studies on T1 and ECV.
I think in addition to findings that you described in severe aortic stenosis, I think there is also another outcome or another kind of a complication may happen for a long-standing severe aortic stenosis, that there are evidence of having a kind of amyloid changes of the left ventricle in addition to hypertrophy and fibrotic changes. So I think in those situations, the MRI may not be extreme help because it's a very mixed sort of finding, and you don't know what would be the outcome of infection. And at the same time, if you replace that obstructed valve with another valve, mechanical valve or prosthetic valve, those changes actually there are regressions. Any comment on that? That is one. Second is that cardiac MRI, because right now one of my fellows are actually doing a thesis on a project on dilated cardiomyopathy cardiac MRI, and almost all these patients have normal coronary arteries. But when we actually analyzed the cardiac MRI finding, we did find a lot of patchy areas of late gadolinium enhancement. The problem is that we do not have facilities to be accurately diagnose a sarcoid or any other conditions, but the coronaries are normal, and Those patients, a good number of them, they have diabetes, and a small number of them also have got some compromised renal function. How will you explain that the patchy areas of LGE in that subgroup of patients?
Yeah. So going to the amyloid first, yes, 15% of aortic stenosis coming to TAVR, especially if it's a low flow, low gradient AS, seem to have amyloid, right? I mean, these are selective series, but it looks like it's not. So, but the lower figure is maybe 5%, 5 to 15% of them can show amyloid of various kinds at pathology or during imaging. You're right. We also know that the prognosis of people, especially low flow, low gradient with amyloid, is poorer than patients without amyloid. Nevertheless, TAVR or TAVI has been shown to be beneficial even in that group. So it don't have sufficient data to say we should not do it in this group or this group is going to do badly. They're just going to do bad because they are kind of at a stage in the myocardium where things are bad. Where it also is true is that if you remember, even in the Braunwald during our times, there used to be this paper. If I remember correctly, it is Karen Bull from Switzerland and his colleagues looked at what happens after you do aortic valve replacement in severe AS. Surprisingly, what happens is after you do aortic valve replacement in severe AS, the fibrotic fraction seems to increase, right? And there was a theory that these are too late and you should have done it early. These guys would be beneficial. At that time, we didn't know what it meant, right? But with CMR, people have repeated those studies. Remember, I told you with T1 and ECV together, I can tell you, is it the myocyte fraction that's affected or is it the extracellular volume that's affected? And there are elegant studies now showing that it's not that patients have developed more fibrosis. It is just that the myocyte component has regressed after you resolve the aortic stenosis. And the relative fibrosis is higher compared to before. So it's not like your surgery or protection during surgery created more fibrosis and caused problems. And so it's essential for us to detect the presence of fibrosis way before surgery so that you start intervening before any fibrosis has happened. And that might improve the prognosis, and which is the subject of the trial that they are thinking of. So that would be the second thing. The third question you had was about patchy fibrosis in dilated cardiomyopathy. That's very common. It's actually a non-specific finding because you have apoptosis going on all the time, right? There's lots of papers showing that cell death is a constant thing in dilated cardiomyopathy, especially as the heart is dilated, more wall stress, more neurohormonal activation. And so those patchy things are very common, especially they all seem to be mid-myocardial, right? They are not subepicardial, which is what you would find in sarcoid or myocarditis, or they are not subendocardial, which you would find in coronary artery disease. So those kind of things are pretty non-specific. Nevertheless, they have significant prognostic implications. So people with LGE are destined to do badly compared to people without LGE.
Those patients with those kind of patchy five changes, when you treated them with the conventional those drugs like ARNI and beta blocker, and their response rate was slower as compared to those where there was no such patchy fibrotic LGE.
That could make sense, although in literature that hasn't been proven. Actually, that's a great project for all of you guys to kind of multi-center, create a multi-center group. And you don't have to upfront do this, but just collate your data and see if medical therapy is influenced by LGE. That is not there in literature. We know LGE is bad. But we don't know. There is some data that remodeling is less, reverse remodeling is less in people who are given ARNIs and had scar compared to people without scar. But the total response itself has not been well studied.
And I think the total LGE volume has to be determined. And then you have to correlate that volume vis-a-vis the response rate.
Yeah.
It's a huge task to quantify that volume and to correlate with the therapeutic response.
The volume comes automatically nowadays in the new software. You'll get the LGE volume automatically.
Correct. So anyway, so I think it's a great talk. I really enjoyed and really pleasure to listen to you once again.
I think Dr. Shastri Hassan wanted to ask.
As usual, excellent talk. Just a quick question. Is there any role of CMR in predicting the CRTR pacing, conduction system pacing, when you have got varying degrees of QRS duration or pattern? Does CMR help in predicting the efficacy of CRTR conduction system pacing?
Yeah, this is still an area of research. The general thinking is more towards where do you place your lead rather than efficacy of therapy. So scar, wherever there is scar, that predicts both whether your lead should be in that place or whether the efficacy of cardiac resynchronization is affected. When we are talking about pacing, say for example, we are talking about left bundle area pacing or something, these are areas of active research right now. So if you have a lot of scar in the area of where a left bundle would be probably present, how does that affect left bundle area pacing, those kind of things. It's very early data. We don't have a good handle on it yet. Is that what you were asking, or did I miss something?
No, same. For example, you have got RBBB pattern or LBB pattern. Some of them respond well, some of them don't respond well. Sometimes, long-standing LBBB will lead to cardiomyopathy where they may be super responders. On the other hand, you have got a long-standing direct cardiomyopathy, then LBBB may there, but you still don't get a good response. So can you make any kind of predictions about the outcome based on the MRI and the conduction?
Yeah, so the literature is highly divided. There are some studies. So the early studies said, yes, it makes a difference. The later studies were not as positive. And this happens with any technology. There's a lot of enthusiasm in beginning, all positive studies come up. And then over a period of time, others do it and say, hey, wait a minute, this doesn't make sense. And then it comes down. So that's a very muddy area. There is no good data that this makes a difference. In fact, there's no good data to help us choose also which patients of LBBB would benefit or not benefit just based on MR. So it's a pretty muddy area.
Okay.
And in fact, further to Shastri's question, I got a comment in the sense that when you do actually conduction system pacing in patients with complete left bundle block with say dilated cardiomyopathy, and you do a CSP conduction system pacing, as you screw in the lead, you are going from this right side to the left side to the left bundle area. And then you determine that if you do an EP monitoring, you find in V1 there is a notch at the nadir of the QRS complex. And then as you go on and continuously monitor that with unipolar pacing, you find that notch moves up to the ascending limb of the QRS complex, and then eventually it ends with the terminal R. And by that, the QRS duration shortens. That is an important determinant. The only problem is that those patients with advanced dilated cardiomyopathy, that logic it doesn't happen, because we do very often conduction system pacing in this group of patients, and that is the kind of observation that we found. And I don't understand the reason for it, but that is what kind of observation. I'm not quite sure that whether this observation has any correlation with the cardiac MRI findings.
Not that I know of. I mean, you have a study right there. You could probably give it to one of your NB or DM trainees. So I mean, these are interesting areas which with the clinical volumes you have, You guys can answer these much faster than any one of us can answer.
Sir, in post-COVID patients, we find lots of young people post-COVID era, they are having cardiac events. Can CMR be placed somewhere in their workup for prognostication of events or things like that?
Yeah, I had a whole set of slides on myocarditis and other conditions that we didn't touch. I stopped because of time. So post-COVID is a pretty muddy area. Nobody really knows what's long COVID, right? It's in an early stage. So the papers that are coming up are the positive papers. Everybody says, I can show this, I can show that. It's same thing is happening in PET, same thing is happening in MR. Everybody says, I can show something. You got to be very careful with these early papers. They are not controlled. They are convenient samples. There's no protocolized collection of data. These are just people who had random MRs during their stay and they say, okay, we found this. So I don't think there's any good evidence for CMR in predicting what happens with COVID. And you know the story of COVID and myocarditis very well, right? So when COVID started early on, one of the things, we had lots of COVID here, but we were not finding myocarditis, all right? And everybody I talked to said they're finding lots of myocarditis. So I called Dr. Fuster in New York, and his hospital got hit very badly. At one time, they had something like 500 COVID patients. And I don't know if those of you who visited Mount Sinai, they have a big lobby and atrium in the bottom. They had to put beds there in the lobby of the hospital. So they had so much COVID. And when I asked him, he said, yeah, we are seeing a lot of myocarditis too. So it didn't make sense. But we kind of, as we went along, autopsy data started coming, and myocarditis was extremely rare at autopsy. These are people who died, right, of severe COVID, but you wouldn't see a myocarditis.
And I think at the same time, it is important that so-called the COVID, myocarditis, COVID heart, MRI, a lot of these patients have other problems.
Exactly.
Completely undiagnosed.
Exactly. And this is why, I mean, you're all PGI people, so I don't have to, this is like preaching to the choir. You have to be very skeptical about literature and think about it carefully. So then what happened is we didn't find anything in my autopsy myocarditis. Then came I.K. Nagel's paper from Germany, and it said among patients who were discharged from the hospital or had outpatient COVID, scanned approximately 60-70 days after the COVID, when they were walking around, 2/3 of them had abnormalities on CMR, and about 60% of them could be myocarditis. And IK is a good friend of mine. And I said, IK, you're wrong. This is not true. And that paper, kind of JAMA cardiology paper, huge press and lots of attention. After that, they were very concentrated studies, both in England and in the US, where they look at hundreds of thousands of patients who were systematically studied, athletes, college football players, military recruits. Myocarditis is 0.1%. So this is the problem with the field of MR. Those who are very much evangelical about MR and they talk and dream MR all the time, they overdiagnose things, including myocarditis. Any little edema or any little T1 abnormality or little GAD, they'll say it's myocarditis, right? And so that is the problem. There's no good diagnosis. And Rabin is very correct. So James Moon in England did a study where he took doctors and medical care workers who were tested for COVID. And then they were followed up and see who developed COVID, who didn't develop COVID. And so they had now groups of people, COVID, no COVID, pre-existing disease, no pre-existing disease. And exactly as Rabin said, when you normalize for pre-existing disease, the incidence of CMR abnormalities in COVID is minuscule. So when you pick up scar here and there and say, this is COVID, and he had a little trope leak, and he say myocarditis, the guy had coronary artery disease and this scar was pre-existing. So when you have pre-existing data suggesting good controls, you find myocarditis didn't exist. So CMR was overused, overinterpreted, and lot of sensationalism in myocarditis and cardiac involvement. And it turns out it's very minimal. Coming back to vaccine, the same story happened. When kids got vaccine, they said, oh, vaccine causes myocarditis. And in the US, those of you who follow the US politics, there are two camps. There's anti-vaxxers and then there are pro-vaxxers, right? So people who don't like vaccination, who think it's an infringement of freedom by the government, why should the government tell me what I should do? Those are the people who also protest against masks and all. So they kind of had a field day, and Fox News is one of their channels, and it kind of said, look, see, vaccine causes myocarditis. Again, when systematically it was looked at, it's minuscule. 99% of that myocarditis disappears. And it is the same as getting flu shot or anything else, right? So it's not like it's something unknown, but it's so less that people overblow it. And the same problem is happening with long COVID. We don't have a good definition of long COVID. And any abnormality found on myocarditis, they say, look, COVID causes long COVID because you see a scar in the myocardium. You have no controls. You don't know what he has, diabetes, coronary artery disease, who knows, right? It's a messy, messy area.
So, so I think in doing a MRI in viral fevers, this is a problem. Like recently, there were a few patients of dengue in which the medicine people, they got a cardiac MRI done. And they found edema which disappeared over a period of 1 year. So I think it's true for all viral fevers where these false positive findings can come in MRI. And if the echo is normal and the ECG is normal, they would normally disappear and they take a long time to disappear. They may take a year or so to disappear. I just have one question, that a lot of patients who have chronic renal failure and they are referred for renal transplant. After renal transplant, many, or I'd say most of them, will recover their LV function. A few will not. So can an MRI help in predicting that which patients non-ischemic LV dysfunction after transplant will recover their LV function? Is there any data on this?
I can't remember exactly for post-transplant LV function recovery. What is generally known is more the scar, the less likely that LV will recover. So it's something worth looking, but I don't offhand recollect any data in that area. But in other conditions, they have looked at this. For example, myocarditis, right? People who have frank myocarditis, heart failure, who are in the hospital, who have had biopsy-proven myocarditis. In them, the amount of LGE predicts who will recover and who won't recover. People with minimal LGE will recover their function significantly. People with a fair amount of 5, 7, 10% of LGE, those guys won't. So you can probably extrapolate that.
And that's why we've told the medicine people, don't get an MRI done in acute viral fever and dengue. You're going to find abnormalities and it will cause tension to the patient without any changes in the outcome.
Exactly. And again, I'm dating my age, but those of you who remember the Dallas criteria, Rabin, BKS, these guys would remember those. There was a lot of debate about what is myocarditis. So there was to be a pathologist, John Fallon at MGH, who said, oh, I can diagnose myocarditis. It's obvious. So at that time, they decided to take samples and took 10 patients of cardiac biopsies and gave it to all the pathologists involved in the Dallas criteria consortium, which made those. And they were all over the place. Some said myocarditis, some said no myocarditis. And after that, it became a little more stricter, that not only you have to show infiltrate, like say there is inflammatory cell infiltrate, you have to show myocytolysis next to that infiltrate, or you have to recover the viral genome from that cell. If you don't, say for example, if you have a sick patient and you give him a lot of pressors, he is going to show myocardial infiltration with inflammatory cells because there's a very famous experiment by a guy called George Rona, who put pumps of norepinephrine into rats. And as the pump started releasing norepinephrine, you could see micronecrosis in the heart. So you get inflammatory cells infiltration in people who are sick, who are in shock, who are in cardiogenic shock and have lots of pressure. But that doesn't mean myocarditis, right? You take a biopsy, you'll say, oh, I saw infiltrative cells, there's myocarditis. You have to show myocytolysis next to it. So once those criteria came up, suddenly Rabin will remember. So in the early 90s, late 80s, mid 80s, lot of myocarditis. In the early 90s, suddenly myocarditis came down. So
I can remember because the MCLA came out with an issue of the Dallas criteria, and we used to sort of read that book, if you remember. And then in 10 years' time, all that, and it's gone completely.
Correct, correct. Yeah. In fact, at that time, I used to think this is a diagnosis in search of a disease. You can easily diagnose it, but there may be no disease associated with it. Yes, please.
Okay. I think I have to leave now. Thank you very much for this meeting.
Asif sir, you are on mute.
Hi.
Dr. Asif, you are on mute.
Okay. Can you hear me now? Hello. Sir, do you advocate that we should go for cardiac MRI in every patient of DCMP before taking decision for ICD?
No.
Yeah, we can go by our clinical and VT demonstration because you said LGE demonstration is very important. And regarding DCMP, whether ischemic, non-ischemic cardiac MRI is a must, it will help to knowledge before taking decision for ICD.
Yeah, so it will certainly clarify the diagnosis, but there is no good data that you can use that primarily to triage who should get ICD or not. So for example, in the ITIL paper, say people with EF more than 35 or even less than 35, 5% or more of LGE compared to no 5%, they had say 4 times the risk or 5 times the risk compared to people without LGE. But the total risk still was 2% a year or 3% a year. So the risk is small. You can separate those groups. So there isn't enough for you to use that and say, let's use this and go forward with ICD. Where it helps you certainly is if your EF is kind of borderline, right? So you are in the 30, 35 range, you don't know, echo has a 7-8% variability. 2 studies have kind of gone here and there. If you do a CMR, you can narrow the variability. So for example, I haven't kept up with the literature. The old literature said echo has what, 8% variability in EF, 2D echoes. So with CMR, you can drop that to something like 3%, 4%. So your confidence intervals are tight. So if the CMR says 32%, you are reasonably sure it will be in the range where you think you might need an ICD. And in that patient, if he also has a 10% scar, and you would say it's probably worth pulling the trigger and going with the ICD. But I would not advocate routine CMR in any of these patients.
Yeah. Thank you. That I was asking.
Hello. Yes. Can I speak?
Yeah, please.
Does CMR have a role in prognostication for peripartum cardiomyopathy? You can decide which patient will need a heart transplant later, early.
Yeah, there aren't that many studies in that area. But if you kind of, there's some which say they would be, but it's not very rigorously done. But in those patients, surprisingly, they don't have that much scar. The peripartum cardiomyopathy people don't have that much scar like regular dilated cardiomyopathy or regular ischemic cardiomyopathy. So I'm not sure whether the scar will be big enough to separate who will recover or who won't, or more importantly, who's going to have a recurrence at a second pregnancy or not. That if you have a lot of patients in your area with peripartum cardiomyopathy or among the PGI group, that might be an interesting question to address and see. Because the biggest risk, unlike dilated cardiomyopathy, once it happens, the treatment is the same, it doesn't change. But in peripartum cardiomyopathy, it may change the outcomes because there may be a second pregnancy, right?
Yes.
So actually, that's a very good idea. You might want to explore that among the group and collect data together. So, good idea.
Good evening, sir. Sir, I have one question. Are you doing cardiac MR in every patient before taking for RFA ablation in idiopathic VPCs?
No. So if we are getting a lot of business from EP because they find sarcoid or infiltrative conditions in everybody. They suspect in everybody. I would say 95% of the MRs we do when the EP suspects sarcoid are negative. So it's not a very, what shall we say, cost-effective way of looking at it. We don't. What is increasing now is PVC burden. So people's triggers have come down, right? Previously, you needed 20+%. Now they are coming down to 9%, 8% PVC burden. They are going and doing PVC ablation. And in my center, they do a lot of epicardial ablation. So they are just looking for patients, kind of. So that is increasing. Again, we don't find a lot of, we find scars, but we don't find a lot of infiltrative disease. And that makes sense, right? Infiltrative disease is rare. It's not that common. After Fred Moradi's first paper, where they said, oh, sarcoid is causing a lot of VT, and in among 9 patients, I found sarcoid in 8. Those were kind of highly selected populations. But if you take 100 patients with VT where you think infiltrative disease is there, I would say if you find sarcoid in 2%, that would be a big thing.
Thank you, sir.
Yeah.
So Sajatya, you can close it. There are no more questions. Is there any in chat box?
I think most of the chat box questions are also done. If Dr. Bhatt had a question, I think maybe if I can. What are the contraindications for CMR? Any problems with pacemaker or ICD patients? Maybe the last question we can take.
Yeah, not anymore, because a lot of devices are now CMR compatible. The fear was if you do CMR in non-compatible devices, you could heat up the lead and cause burns, or you could cause any abnormality in the device. Then there was never a fear that the device would fly away into the magnet or anything. But it was mainly whether you would get thermal burns or something like that. But it doesn't seem to be a big thing. Even there have been studies looking at non-compatible pacemakers and CMR, not cardiac. These are non-cardiac studies with non-compatible pacemakers. It doesn't seem to cause any big problem. It causes a fair amount of artifacts. So you need to have a center where they are used to be able to change sequences. They have physicists who can devise sequences which can mask some of the artifacts. But I don't think there's a big contraindication anymore. There used to be a contraindication with renal dysfunction. That, as I said, is not a big thing anymore. So it's kind of becoming a minority where we cannot do CMR.
Is it same for 1.5 Tesla or more than 1.5 Tesla? They both are safe?
Yeah, you're right. No, 3 Tesla, nothing is safe.
Nothing safe.
I mean, it may be safe, but it hasn't been approved to be safe. So one of the problems in my center is we have a 1.5 Tesla sitting next to a 3 Tesla in the same room. So there's just a divider between the two. So that makes it a little more tricky. If the patient kind of strays into the 3 Tesla zone, it could be a problem. So yeah, nothing is approved for 3 Tesla officially yet, as far as I know.
Okay, sir. So with that, I think we'll end this session. So we all who have joined today, there were lots of people today, and we all, I think for all of them, I can surely say that we are very lucky that we could you could make time for us and help us know something about cardiac MR, which is not very freely available here, but which seems to be something that we all should be aware of. So I think for all of us here, I think there's a, as you were mentioning to Dr. Smith, we all are very lucky, and there's a huge spectrum. So I think right from the 80s, I think the youngest person here is someone who has passed out in 2021, as I can see. So all of us, I think everyone, each and every one of us is very lucky, and I think this has been a very educative session for all of us. And thank you, sir, for taking time out and giving such an exhaustive talk. With that, and with taking a leave of with leave of all the panelists, I think we can close the session right now.
Yeah,
Thank
no,
you,
thank
everybody.
you. I appreciate it. One suggestion, you guys are
Sir.
such a powerful group. I think you should start a kind of a cooperative program on a database and try to identify 2 or 3 diseases where you have expertise. And if nothing, at least build a clinical database. If you need some help, I can get you that. I can get you some statistical help. But at least start building. I mean, look at this, 20 plus years of graduates from PGI, correct? So just put together something and start enroll. These are all web-based, so you can enroll your patients. You can choose your conditions that you want to focus on, and it can become a scientific powerhouse with the volumes that you have. So,
Dr. Shastri is here, sir. This India Live, we had formed few groups. So Dr. Bali is about to start with a periodical magazine, which would be 3 monthly. And Dr. Shastri is planning to start different registries where we can, send our data to that registry and have a PGI registry.
exactly.
So,
That would be good, because then you can build a core group. And why not? You could apply to ICMR for money, right? I mean, they have tons of money, departments of science and technology, ICMR, right? So they could fund some of this. You can hire statisticians, you can hire database people who can clean up the database, and it's doable.
Problem is, we have a lot of inertia and no time.
Yes, that's true. You probably are all at a stage where you can cut down your clinical practice a little bit, maybe not do a CRT at 11 p.m.
What we have to do, we have to employ somebody, spend some money, employ somebody, and then collect the debt.
Yeah,
Good,
ICMR has a lot of money. ICMR has a lot of money. So,
sir, we are now collecting membership for a fee for our group also. So that is also in way. That way we'll have something to start with, and then we can manage. I guess we can manage things with some help here and there. Things would be there.
We should do something. We'll do.
Sir, we should. It's a long due thing.
Yeah, we will do it.
yeah, I mean, this is amazing talent here. It's like the best of India. So
by the end of the calendar year, we'll come out with a paper.
Yes, sir. Hopefully. Thank you, sir. And a good night.
So good to see you all.
Night,
Bye.
Bye.
Hey, Harinder, how are you? You just switched off. How are you?
Yeah,
You're breaking up. Can't
it was
hear you.
nice listening to some part of your lecture.
I know you're busy
It was
putting
lovely
stents.
listening to some part.
Good to meet you.
Not anymore. All good?
Yeah, all good. How about you? Are you visiting this side or no?
Yeah, things are okay.
Co-
Maybe sometime in September.
Yeah.
Maybe sometime in September.
We'll catch up.
Look
Are you
forward.
coming? Are you coming to ESC?
Maybe TCT probably.
Okay. We'll connect sometime.
Okay, take care. Bye.